Thank you.
Thank you, Hernan.
Hi there.
Doreen and Melva. Hernan is a pediatrician. Says he's retired. It sounds very busy. He's in Las Cruces. And Hernan, Doreen Campbell is joining us from the Pewaukee School-Based Health Center, where she is recently joined as a clinical therapist, a behavioral health therapist. And Melva is with us from Arizona. And Melva, is that correct? The Gila River Healthcare?
Yes, that's correct.
Where Melva is a registered dietitian.
Very good.
Okay. So, without further ado, I'll get underway. And having just welcomed you to TPICC, while Hernan has been on TPICC before, Doreen and Melva, just by way of at least a little bit of an introduction to TPICC. TPICC operates a bit differently than the rest of our telepsychiatry offerings in that it is ordinarily emphasizing case conferences on the first Wednesday noon hour each month, oriented primarily to pediatric primary care providers, so pediatricians, nurse practitioners, physician assistants who are providing pediatric medical care. Nevertheless, registered dietitians and clinical therapists are more than welcome to join us. We're assisting providers with the clinical management of their patients. And while the format is similar to other telehealth conferences, it tends to have a shorter didactic portion, which I'm going to make exception to today, and followed by 3/4 of the session on case conferencing. We're broadcasting live from Studio Envision, and we connect with you online. If you ever have a case to present, please find our presentation form online at envisionnm.org. You can also access information about the presentation on our calendar, and evidently you all are familiar with the registration process by now. I mentioned taking exception to the usual short didactic. I've billed today's session as a much longer session about psychiatric differential diagnosis in the pediatric clinic. Doreen, there have been similar versions, have oriented a bit more to school-based health centers, for example. Up till now, we've talked about assessment instruments and screening tools in these conferences. And I think, Melva, you may be the one who is meeting me for the first time. I'm a pediatric psychiatrist at UNM, where I practice in the pediatric clinic and in school-based health centers and support behavioral health providers such as Doreen and the nurse practitioner she works with and others around the state. And I'm also provide direct services, as I alluded to a moment ago. So our talk today about differential diagnosis could also be referred to as, if not ADHD, what is it? Because youth are often referred, especially in the school setting, but also by those in the school, to primary care providers in the community for evaluation and medication for attention deficit hyperactivity disorder that we've all come to know as ADHD. However, comprehensive clinical assessment frequently finds these students having other often coexisting conditions present that impair their learning. And it's so important to consider the various diagnostic domains which feature hyperactivity, impulsivity, and off-task behavior that I thought it'd be important to dedicate the entire session today to talking about that. And our goal in doing so, that is what we're really aiming toward, and hence our orientation compass there, is to consider the major diagnostic domains during behavioral health assessment. And I'm making the distinction here about major diagnostic domains because we know that in the DSM, currently 4, about to become 5, the Diagnostic Statistical Manual, that when we look up these conditions, there's an overwhelming amount of detailed diagnostic criteria, some of which you'll see today when, for example, depressive disorders are covered. But by and large, we're going to stick more to the major hallmark features. So here's a referral example that comes from the school. And at Pewaukee to Doreen, that may come as a written referral right to the school-based health center. When Hernan has been in the pediatric clinic, he may receive a referral that comes to him from his clinic staff or even is brought to him by a parent or other caregiver. About a third-grade boy named Spivey, and the school personnel are asking for an ADHD diagnosis and prescribe Ritalin. Well, we need to ask ourselves, does the referral diagnose and prescribe? That is, does the referral alone give us enough to diagnose and prescribe treatment? Well, we really need to consider the diagnostic possibilities. We need more information. Well, where do we go? In the school-based health center, we have the privilege of going around to talk to others in the school, or better yet, they can join us in a team conference like the one I just was attending at a middle school. At the pediatric clinic, we may be asking the parents or others in the school to bring us the information. So those are ways that we can do it, and from where and who we can look at by asking the teacher. What's seen in class that suggests ADHD? Well, Spivey doesn't pay attention, he doesn't listen, his assignments are incomplete and often not turned in, and he seems like he's somewhere else. Is he impulsive? That is, does he ask before he thinks? Act before he thinks, that is. Well, sometimes he does. Other times, well, he doesn't, but generally he's not following rules and directives. Is he hyperactive? Not today. Yesterday he was. It's intermittent across time and in fact across settings. Is he aggressive? Well, he's been physically aggressive with his peers and verbally aggressive toward adults and peers. He's easily annoyed and frustrated, evidencing some mood difficulties. And we ask if a parent has been notified. Well, parent's been notified of the referral and the problems generating it. Well, the teacher reports inability to reach mom and others in the family. So we find out from the school counselor that there have been poor academics and some behavior problems this year while Spivey is retained in the 3rd grade, following many 2nd and 3rd grade absences the past 2 years. We ask about if there have been any recent referrals, such as to the assistant principal for aggression. And in fact, he's received those referrals for the aggressive behaviors that the teacher mentioned. He's often teased and bullied by peers. He's being tested for special ed. Asterisk there because that's a great opportunity to find information. And we ask the counselor what's going on at home. We hear there's lots of chaos, and that's why it's been hard to reach mom. We also find out from the school nurse that Spivey's had multiple somatic complaints the last 2 school years, especially digestive tract like stomach aches, GI tract stuff, and headaches. And the annual health screen and physical exam the past 2 years has revealed that he's overweight but otherwise entirely within normal limits. He's had frequent visits this year for vague complaints and unclear reasons, such as appearing, and he appears sad and needy. Well, I mentioned a while ago, educational diagnostic evaluation in progress creates such a great opportunity to find out how things are going with that assessment process-wise, and also what the findings are. Well, during cognitive testing, Spivey has been observed to be slow with his verbal or language processing and intermittently distractible. However, he's not been found to have any vision or hearing deficits, and that actually was reported by the teacher. The cognitive testing has revealed deficient verbal intelligence that is mismatched with his low to average performance or nonverbal intelligence. The full-scale IQ, however, is uninterpretable, considered so because the disparity between the verbal and nonverbal intelligence is greater than 1 standard deviation. Evidently, some of the language difficulties have become evident during the psychoeducational evaluation, as evidenced by the referral for a speech and language evaluation. Well, based on what we've been able to find out so far from the teacher, counselor, school nurse, and educational diagnostician, does it seem as though Spivey has ADHD? If so, which type? What's the evidence for ADHD? What evidence might we say is not for or against having ADHD? Well, clues to that include the age at onset, whether the features are consistent or variable, and other clues that we're going to find out along the way. The differential diagnosis of ADHD becomes very large, as we're going to see, because numerous psychiatric problems in youth feature the ADHD hallmarks of distractibility, impulsivity, and hyperactivity, which is heightened motor or bodily activity. And concentration difficulties are symptomatic of virtually every psychiatric disorder listed in the DSM and many related comorbidities, including subsyndromal conditions. Well, there is a practice standard from the American Academy of Child and Adolescent Psychiatry, published in 2007, that speaks to this, stating a variety of other disorders can be mistaken for ADHD or can co-occur. And that's a lot of what we're talking about today, is summarized right there. There's also some empirical support came about from a meta-analysis of studies that Madison performed around year 2000 that have shown that various mental health issues underlying disruptive behavior at school, including not only ADHD, but other disruptive behavior disorders, mood disorders, anxiety disorders, as well as adjustment, substance use, learning language, and other developmental disorders. So the differential diagnosis becomes quite broad. Well, if it's quite broad, doesn't that mean that a lot of other conditions can present like ADHD in youth? So what else presents like ADHD in youth? So this brings us to our main objective, is to identify those major diagnostic domains which feature youth distractibility, impulsivity, and hyperactivity. And here they are. And what we're referring to here as the diagnostic domains include ADHD and the other disruptive behavior disorders. Mood or affective disorders collectively are another domain. Whoops, sorry about that. So are the psychotic disorders. Anxiety disorders including PTSD. Disrupted early memory and attachment. Doreen may be thinking about that one. Doreen and others may be thinking about dissociative disorders. There are neuropsych considerations that we will go over as well. Sleep problems, substance abuse, pervasive developmental disorders, or known as PDD, or autistic spectrum disorders. And there are other developmental considerations and medical conditions. Sound familiar from what was pointed out from Madison earlier with some empirical support from this list? I think it does, and I hope you're finding so too. But just to make sure that we really cover this topic, we need to consider what are psychiatric disorders and what are their causes. And that brings us to these further objectives of defining a psychiatric disorder, distinguishing them from subsyndromal conditions, and understand etiology using a biopsychosocial model. Well, by nature, a psychiatric disorder is severe and pervasive. It is persistent or recurrent, causes impairment, and has biological, psychological, and social origins. And I think it's worthwhile mentioning that one of the best sections, best things that I've read that gave me some further insights about the whole diagnostic purpose and really understanding what a psychiatric disorder is a section in the early part of the DSM that describes a psychiatric disorder as having these characteristics. Psychiatric disorders also fit a biopsychosocial model that originally explained a medical illness, heart disease, and then was expanded to explain asthma, other medical illnesses, and the psychiatric disorders. And it explains etiology by identifying genetic predisposition and other constitutional aspects, psychological experiences, such as being impacted by early childhood experiences while growing up in one's family, and how that determines the psychological functioning and defensive functioning of an individual that permits them to cope and problem solve, and how they function in relationships, which comes to the social and environmental factors. Well, when we look at ADHD, while we embark on going down that list of differential diagnoses, as an alternative to, as mentioned earlier, rather than going through all of those diagnostic criteria, which must total over 15 for ADHD, we can distill them into these hallmark features of hyperactivity, impulsivity, and distractibility. And point out that the name ADHD, including attention deficit, is a bit of a misnomer insofar as there is not really a deficit of attention from a clinical standpoint. It's that one has a deficit of concentration, But in research, it's been shown that there are three kinds of attentional problems that lead to getting distracted, make it difficult to get back on task and to remain on task. The main types of ADHD correspond to the hallmark features. so that the predominantly inattentive type in the middle has primarily deficient concentration. Predominantly hyperactive and impulsive type has the first two hallmarks, and the combined type have all three. And you remember earlier on the clues to whether Spivey has ADHD? Well, it's the early onset that's important. That ADHD typically occurs before age 7 by the time the child is in first grade and causes impairing symptoms. So while we're working with a high school student who comes in to our clinic or school-based health center talking about difficulty concentrating, staying on task, and accomplishing schoolwork, and it really became a problem in their junior year of high school for the first time, that's less likely due to ADHD. Well, this is a rather packed slide, and I've got a few of those in here so that you have the information. It really aims to make the points that are in bold and underlined. That ADHD is a clinical diagnosis made by comprehensive assessment that considers numerous sources of information in addition to the clinical interview and observations. That the diagnosis is made on the basis of behaviors across multiple settings rather than on the basis of a single clinic visit or a single classroom or home behavioral rating. There's no specific diagnostic test for ADHD, and therefore students are not tested for ADHD. However, we hear often parents, other guardians, caregivers, case managers, and other providers talk about a student needing to be tested for ADHD. Okay? It really comes about by way of the comprehensive assessment rather than a test. However, neuropsychological testing and other testing can be useful to support an ADHD diagnosis and reveal coexisting learning, language, and other developmental problems. Neuropsychological testing alone does not diagnose ADHD. Well, in looking at the etiology of ADHD, while psychosocial factors can add into the severity of the symptoms, the etiology is largely neurologic. Commonly in what's considered primary or so-called developmental ADHD, it probably results from normal yet delayed brain development, especially involving the frontal circuits or the frontal lobes of the brain. And it's because of it being a developmental problem that a great percentage of youth outgrow ADHD as they go through their teenage and into their adult years, and yet we know some do not. Okay? There are some who have acquired ADHD due to a head injury or another condition that causes them to develop ADHD features later. And ADHD is largely considered a behavioral syndrome of many causes, such as traumatic brain injury, or we even know that in utero alcohol exposure causing fetal alcohol effects and fetal alcohol syndrome can be a cause of ADHD. The acquired or secondary ADHDs can be caused by, in addition to traumatic brain injury, seizures causing attentional problems. I mentioned the prenatal exposure. Perinatal insufficiency of oxygen, nutrients can also contribute, and it can also be caused by chromosomal or genetic abnormalities. Now I'm adding in here a similar condition, but it's has much more pervasive impairment called mild neurocognitive disorder that really goes along with the neurologic causes. And the neurocognitive disorders can cause problems with attention, language, memory, executive functioning, even perceptual motor abilities due to widespread brain involvement. And again, it's mentioned because sometimes we'll see somebody who has a variety of ADHD. They're having trouble with language comprehension, word finding, as well as expressive language. They're also having difficulties with learning, and they could meet this single diagnosis explaining all of those difficulties rather than ADHD plus others. But when we get back to looking at other differential diagnostic associations with ADHD, or what else can cause ADHD, oppositional defiant disorder can bring on features that look like ADHD, but it's usually comorbid with ADHD, in as much as 3/4 of cases of ADHD are comorbid with oppositional defiant disorder. And Russell Barkley, the psychologist researcher of ADHD and other disruptive behavior disorders, has developed a 4-factor model that explains that very well. Interestingly, ODD can also be considered a mood disorder because there is a disorder of anger, excessive anger, and difficulty handling anger. No, it's not. Well, that's the ODD coming through. Conduct disorder involves a pattern of violating major age-appropriate societal rules and the basic rights of others in areas of aggression that can include aggression toward other people, toward animals, toward property, involve theft, being deceitful, and some of these individuals develop antisocial personality in their later years. There also can be a diagnosis of disruptive behavior disorder not otherwise specified, or NOS, which can involve subsyndromal features of ODD with or without subsyndromal features of conduct disorder. Or in an individual who has ODD, they are evolving conduct disorder and already has some of its features, such as the oppositional defiant student who is starting to be truant and running away from home. Next are other mood or affective disorders. And before I go on to that, I'd like to ask if Doreen, Melva, or Hernan, do you have any questions thus far?
This is Doreen, and no, I don't.
Well, Doreen and Melva and Hernan, please chime in once you do. I am motoring through this pretty quickly while wanting to keep the view of the forest and looking less closely at the trees for purposes of keeping that broader perspective and also getting through all of it in one conference, which is part of what sets TPICC apart from some of our this presentation and our other telehealth venues. For example, I'll mention in our school-based health center quality improvement webinars, this is really a two-part series. Well, the mood and affective disorders is an area where we will look a little more in depth because mood disorders are so prevalent. There are the depressive disorders and the bipolar disorders. And essentially, the theme in both is that you have major varieties and minor varieties, okay? And those that are more self-limited and those that go on considerably. Now, that last point is especially true of the depressive disorders that I'll go into more shortly. Both major depressive disorder and the bipolar disorders have major depressive episodes, and these can become recurrent. So you remember earlier when talking about what is a psychiatric disorder, that it's pervasive or recurrent. It's the recurrence that applies very well to the mood disorders. And yet, there are examples such as Dysthymic disorder, which is a more chronic depression. So here we'll look a little more closely at the depressive disorders. In red, you see major depressive disorder, MDD or major depression, Dysthymic disorder, double depression, depression NOS or depressive disorder not otherwise specified, and the adjustment disorders. And this is listed purposely as a continuum from major depressive disorder being most severe and the adjustment disorders being the mildest and usually self-limited. Major depressive disorders, while most severe, actually have ratings from mild to moderate to severe. They're generally episodic, one or more major depressive episodes. Dysthymic disorder, usually considered lower grade because it has fewer symptoms than major depressive disorder. But it's longer lasting, more chronic rather than episodic, with a minimum of 1 year duration in youth. That's 2 years in adults. Double depression, not a term that's actually listed in the DSM, but we refer to it as the combination of dysthymia plus major depressive episodes, okay, or major depressive disorder. And this is a condition that can be especially chronic. Depression NOS is being referred to as a minor or subsyndromal depression, having even fewer diagnostic criteria. And the adjustment disorders with depressed mood actually refers to about 3 varieties of adjustment disorders. And they are started in response to a psychosocial stressor or multiple stressors. Was that Hernan or somebody chiming in?
No, I was just coughing. I'm sorry.
Well, that's okay. And certainly this list is nothing to sneeze at, but it can sure give us a lot of, I think, places to hang our hat on when thinking about how youth present to us clinically. Now, I said we'd look a little bit more at some of the diagnostic criteria. I've distilled the major depressive features into this list of having depressed or in youth irritable mood, markedly diminished interest or pleasure. One or both of those are needed to make a diagnosis of major depressive episode, whether it's in major depressive disorder or in bipolar disorders. And in the screening tool, PHQ-2 and the PHQ-9, the assessment instrument that we've talked about in earlier installments, these 2 questions are really pivotal. There's decreased or increased appetite or weight, so there's a disturbance with that, as there is with sleep. There's diminished energy. There can be psychomotor slowing, and the agitation, the psychomotor agitation that can result in younger youth can appear like the restlessness of ADHD. Feelings of hopelessness, worthlessness, or excessive inappropriate guilt can be symptomatic of major depressive disorder. So can concentration difficulties that again can cause depression to look like ADHD. And importantly, there can be suicidal ideations, thoughts or wishes about death, as well as suicide plans or attempts. Now, depressed youth are frequently irritable and have associated anxiety. And that really sets them apart in their depression from adults. They often are distractible. And younger children especially have that psychomotor agitation that looks like hyperactivity. Slowing develops as a depressive feature with age. Youth also present with somatic complaints such as stomach aches and headaches. Reminds you of Spivey. They can have hallucinations. In addition to psychomotor slowing, hopelessness, anhedonia, delusions, diurnal variations increase with age. I mentioned dysthymic disorder as chronic, that is, it's non-episodic, and it's typically lower grade than major depressive disorder, where there is depressed and or irritable mood for most of the day, more days than not, and require only 2 diagnostic criteria from this list of several. The poor concentration that can result is at times reminiscent of ADHD inattentive type. And dysthymia, by the way, is a common comorbidity in overweight youth where there can be overeating, hypersomnia, low energy or fatigue, low self-esteem. Pediatric bipolarity is the other main area of the mood disorders. And in youth, bipolarity presents with extremely irritable and labile moods, where there's frequent severe mood swings and bursts of euphoria, as well as bursts of irritability. Typically there's pressured speech, so it's hard to interrupt the individual, and they keep going on and on. Grandiose ideas, I'm going to do this, and then I'm going to do that. Delusions, grandiose delusions can become they would be out of proportion with the reality that most experience. Racing thoughts, flights of ideas, risk-taking. There can even be hypersexuality, sleep disturbance, and prevalence of hyperactivity, impulsivity, and distractibility. The prominent irritability of pediatric bipolarity has been written about extensively and is a key developmental difference between the bipolarity of youth, that is much more irritable, prominent irritability, as compared to adults. The age of onset of bipolarity seems to be decreasing to the point where it's now thought to begin in youth. A depressive episode, such as a major depressive episode, however, can be the first manifestation. And commonly we see youth who are developing bipolar disorder who received an ADHD diagnosis beforehand. And that reminds me of somebody I was working with in clinic this morning. Okay, suicide risk, increased substance abuse, and other comorbidity is very high in youth with bipolarity. There's some interesting characteristics that were pointed out about pre-pubertal onset bipolarity. That is, bipolarity that begins in elementary school, that described it as chronic, non-episodic, that is continuous rather than the big mood swings. And yet there is cycling up and down that is so rapid that there ends up being a mixture of up and down, and that's referred to as a mixed manic state. Bipolarity can be comorbid with ADHD and conduct disorder, or have the features of those conditions as their initial manifestations. And that over the clinical course of bipolarity, from childhood to adolescence to adulthood, these features change in their prominence. Cycling can become less frequent. There can be more distinguishable episodes and less of the mixed states. Well, now we're going to move on to the state of psychosis. which can be thought about and therefore separated into active psychosis and more gradually developing primary psychotic disorders, such as schizophrenia, that's being referred to as early onset psychosis. Now, actively psychotic youth can be distracted by hallucinations and delusions. They can become hyperactive and impulsive, and they can actually have a state of catatonic excitement or restlessness that can present like hyperactivity. Yet, actively psychotic youth can be depressed, they can be manic, they can be abusing substances, or they can be psychotic due to another etiology. And that brings about this whole differential diagnostic list of what can be causing acute psychosis in youth. But rather than to stop and look at all of those trees, I want to take a look at this other area of the forest having to do with the more insidious onset of schizophrenia in youth. There's typically an early emergence of various preceding developmental and behavioral problems, followed by the gradual onset of psychotic symptoms and eventually the full syndrome. Males have been reported to have this earlier insidious childhood onset following early signs of abnormal development, such as soft neurologic signs, language and learning difficulties, okay? There can be depressive symptoms and conduct problems before a diagnosis of early onset psychosis. Attentional problems and hyperactivity often characterize the early history, as does the language and learning difficulties. Okay? Often there's a diagnosis of ADHD by elementary school that precedes the diagnosis of schizophrenia. So this really speaks to the next point, that there are significant developmental deficits in 1/2 to 3/4 of children studied who have eventually developed childhood schizophrenia. And these developmental deficits are, again, in language, also in motor difficulties such as the soft neurologic signs, and problems with social functioning and adaptation. Academic difficulties are common, resulting in retention in 50% of students and special ed placements in as much as 2/3 prior to the onset of psychotic symptoms. And there can be peculiar social interactions and relatedness and mannerisms that can present like pervasive developmental disorders, that is, the autistic spectrum disorders. Well, I'm going to move on to the anxiety disorders in youth, which are listed here in order of age of onset. So the anxiety disorders that usually first appear in youth are specific phobias, such as excessive impairing fears of spiders and snakes or something else. And usually it's later on in childhood that problems such as social phobia or panic disorder develop. We're going to focus on separation anxiety, generalized anxiety, and post-traumatic stress disorders. Separation anxiety involves recurrent excessive anxiety, fear, or worry concerning separation from home, but what it's really about is the major attachment figures there, and perhaps being worried about what might happen to them when one is away from home. Repeated physical symptoms, especially GI like tummy aches and headaches, remind us of Spivey. And separation anxiety disorder is a major cause of school refusal. However, other causes of school refusal commonly include depression, psychosis, and the other anxiety disorders. Now, generalized anxiety disorders can be thought of as generalized anxiety with excessive anxiety and worry about numerous events or activities, including performance at school, in a recital, in a sport, and even social interactions. Symptoms can include restlessness and concentration difficulties that can look like a presentation of ADHD. And here too, we often find associated somatic symptoms of headache and tummy aches. Posttraumatic stress disorder is a really big syndrome that is developing in a lot of youth who have persistently re-experienced a past significant trauma, as evidenced by repeated behaviors, emotions, bodily sensations, flashbacks, intrusive recollections, and other intrusive thoughts, and nightmares or bad dreams. It can even include hallucinations and cause panic attacks. Okay? There can be increased arousal symptoms causing concentration difficulties, anger or reactive behavioral outbursts, hypervigilance, and an exaggerated startle. There can be memory and attachment considerations that can lead to concentration difficulties, and also the normal development of which can be very disrupted by trauma, which these considerations can be an entire presentation in and of itself, which I'm going to just gloss over as saying that early implicit memories develop without the usual experience of I'm remembering something, as in declarative memories, and that there can be implicit memories of early childhood abuse, witness violence, and chaos that can impact an individual's behaviors, emotional states, and thinking for decades to come without one's awareness. There are ways of measuring kinds of attachment and disorganized attachment where there's been the greatest disruption by multiple shifting caregivers, along with perhaps multiple moves, but often in cases where there's a lot of chaos at home and trauma can really have a great impact on disrupting the cognitive abilities and memories of that an individual has for their lifetime. Dissociative disorders can be a big cause of attentional problems in youth, and PTSD can cause youth to dissociate. By the way, earlier in the list of anxiety disorders was inclusion of panic disorders. And in PTSD, there can be panic attacks that are triggered by recollections of and stimuli associated with past traumas. Sleep problems are mentioned because we have such an epidemic of insufficient sleep. Signs of sleep deprivation have been misdiagnosed a lot as ADHD because sleep deprivation can cause concentration difficulties, problems with following directions, staying on task, can develop irritability, impulsivity, hyperactivity, in addition to a host of other problems. Children with ADHD are found to have more fragmented sleep, though there's the same quantity as those who don't have ADHD. This is independent of whether they're prescribed a psychostimulant medication. Substance abuse can cause ADHD kinds of features, either because of intoxication with stimulants, such as cocaine and methamphetamine, and abusing the psychostimulants that are prescribed to treat ADHD, okay? distractibility, diminished concentration long term, impulsivity, psychomotor agitation can look like hyperactivity. All of these can contribute to something that looks like ADHD. The pervasive developmental disorders or autistic spectrum disorders can cause distractibility due to the individual's fascination with parts of rather than the totality of an object. Okay? And the hyperactivity and impulsivity can be an appearance that develops in the course of the restricted repetitive range of behaviors of these individuals. There are other developmental considerations, including delayed but progressing development, which is akin to developmental ADHD. Learning language disorders can cause youth to become bored, appearing as though they're easily distracted, okay? Have difficulty understanding and or processing. And I've included young age because we expect toddlers and preschoolers to have shorter attention span and less ability to remain on task. But it's interesting to see how often we receive referrals for youth under 5 years old. Medication mimics or medical conditions that mimic ADHD are reminiscent of those with substance abuse, such as psychostimulants when there's prescribed and taken when there's no ADHD, medications like albuterol and theophylline that have been used to treat asthma can cause a lot of restlessness. Diphenhydramine, though known as Benadryl, though sedating, can cause a paradoxical activation. Thyroid disorders and other metabolic problems such as hyperthyroidism, lead poisoning, lead exposure, is a known cause of ADHD. ADHD features can occur because of a central nervous system infection, peripheral infections such as Epstein-Barr virus in an individual who has mononucleosis. And there are other medical conditions as well. So there we have gone through the entire list of the differential diagnosis of ADHD with rather a glossing over of the items having to do with memory and attachment and dissociative disorders that I would love to present about some other time. But it's not only the list of differential diagnostic possibilities, but the comorbidity of these conditions that are part of the clinical picture, and we need to anticipate that, because clinical assessment often reveals more than one disorder in the following two major ways. Coexisting disorders often resemble ADHD, such as when there's a depressive disorder like dysthymia, an anxiety disorder like PTSD, a disruptive behavior disorder like conduct disorder, and a neuropsych condition like traumatic brain injury. Okay? Other disorders often coexist with ADHD and become part of the clinical picture. I mentioned previously, 2/3 to 75% of youth with ADHD have at least one other psychiatric disorder. Again, pediatric bipolar disorder is found to coexist with or initially present with features of ADHD and or conduct disorder. So it becomes as important to assess and treat the coexisting conditions as it is the ADHD itself. So using Venn diagrams in the first example, coexisting disorders often resemble ADHD. Here you have the mood disorder, like a depressive disorder, with a disruptive behavior disorder and an anxiety disorder together that can look like ADHD. Or we have the other conditions such as oppositional defiant disorder and other disruptive behavior problems coexisting with ADHD, and the presence of bipolarity that has been talked about today. So here's a listing of the various conditions that can coexist with ADHD, many of which have been mentioned. But again, we often find the language and learning difficulties. So far we've talked about the differential diagnosis of ADHD and other disruptive behaviors, as well as the comorbidity. Next, we identify contributing, exacerbating, and other associated factors, such as the medical conditions, those that have been mimicking ADHD, like hypothyroidism or hyperthyroidism, other metabolic problems, can also exacerbate ADHD. So can the illnesses that were mentioned. And psychosocial factors, again, while they don't cause ADHD, they can certainly worsen the clinical picture. So in summary, youth who are referred for evaluation of and medication for ADHD frequently have other, often coexisting conditions that impair their learning. Various diagnostic domains feature the hallmarks of ADHD, and the comorbid disorders and exacerbating factors also contribute to the clinical picture. Well, I see that we're out of time. I was hoping that we could go on to the case as we look at the implications of everything that's been presented today and look at those implications for the case of Spivey, but I see that we're going to have to look to doing that on another day. So I thank you for being here for what's become a very extensive presentation. I would be glad to talk with you about questions or concerns that you may have as I foreshadow the case, and have you know that your references are in your handout. I'm wondering if anybody has another case for next time. Remind you that our next session will be Wednesday, March 6th during the noon hour. Topics could include treatment approaches, specifically psychotropic medication, or youth substance abuse. And I welcome all of you to take advantage of telepsychiatry consultation. As Doreen has found out, it's available to you to talk about the students and other youth that you see. If you wish to receive your continuing education credits, Kevin will take your attendance now so we make sure that you receive your credits.